I would like to call to order this meeting of the Assembly Health Policy Committee. It is 10:02 on August 6th, and let's start with roll call, please.
All right, Mr. Presverdia?
Here.
Ms. Zalato? Ms. Allard? Mr. Constant?
Here.
Mr. Dunbar?
Here.
Ms. LaFrance? Ms. Quinn Davidson? And Mr. Rivera?
Present.
Thank you.
Kennedy's here.
Great. Thank you, everyone, for being here. I am going to, before we get started, make an amendment to our agenda. I would like to add under new business, prior to the alcohol tax expenditures for prevention, I'd like to add a report from the health department. Is there any objection from members on adding that agenda item? Hearing and seeing none, we're going to add that as the first item of new business. I'd like to start with that for a couple of reasons. One, I'd like to give the new and I always miss this word. Is it interim or is it not approved yet? But the person who is currently sitting in the seat of the health department director, Joe, I would like to give him an opportunity to introduce himself to the committee, and also to take some time to give us an update from his department. Specifically, I believe he's going to give an update on COVID-19, and there may be some other areas that he wants to update us on. So I'd like to start the meeting with that, and then move on to the other items on the agenda. So without seeing any objection, let's move forward with that. Joe, if you would like to turn on your camera, and first, it'd be great for you to introduce yourself, share a little bit about yourself, and then move right into to your report.
Outstanding. I want to thank everyone for having me here today and even considering me for the job. You know, it's a big honor to get nominated for this job. And I can't say enough about what an awesome team that I get to work with. So about myself, my name's Joe Gerace. I live here over by the zoo. I'm married to a local physician, 9 Sanders, over at Anchorage Neighborhood Health Center. With that said, I would say that it's the real honor here is getting to work with the team that is the health department. And to talk about it a little bit, my vision of the health department, I see us like the third part of the trident of first responders. I want to kind of take the time to say that the health department has a ton of operations, and not just animal care and control or ASP, ASC, but just what the public health nurses do. They really are the third element of protecting the citizens of Anchorage, the MOA, from a ton of things. And it's not just COVID, right? It's opioid epidemic. It's all the things that go into our community health. And as we get ready to take on the mass care piece of homelessness and housing too. So I see it as a great opportunity, because this is the segue to me. Besides all the stuff that you read in my bio, I'm an outstanding administrator, but outstanding administrators, sorry, my computer froze. Outstanding administrators recognize quality staff is the key to that. So with that said, I really think that the opportunity for the health department here is that we can become an agency that is supportive of the MOA and a ton of things. We have, 15, the fire department goes out on fire and medical emergencies, the police respond to calls. We're responding to those same things. And so having an administrator that with a background like me, I have a very strong first responder background. And I think that's the difference. We have excellent medical people here in the public health nurse and the doctors that we have on staff. But the piece that I really see that I can be supportive of is the operational piece. And that's where I really have that strong background from national and local disaster response for the last 30 years. The last 10 years, that's kind of been my calling. I owned some businesses that allowed me to be heavily involved in the disaster response all over the United States, from hurricanes to earthquakes to shooting events in Vegas to the fires. I just came back from the fires in California. Last year, I spent 6 weeks. I was just down there right before this appointment. And I think that really is the piece that Alaska, it is a unique place. So the lower 48 doesn't get what it's like here in Alaska. So with that said, I think that's the opportunity I bring, is that global view with the real focus on the uniqueness of Alaska. And so what that looks like, that's hard to say. I've been really, really dialed in on what we're needing to do at the health department. So I apologize. I've met a few of you. It's been a real privilege and honor, but I've been trying to wrap my head around what operating the health department really looks like. We're 2 weeks in, and I'm just wrapping my head around trying to take care of the business, that's from supporting the team to not forgetting all the things that are the health department. The COVID-19 response is a great example, and I'll stop after this. The COVID-19 response, we've been so focused. We're not the COVID-19 department. We're the Anchorage Health Department. And with that said, I think we really need to be talking about the totality of things. The opioid epidemic was ongoing since, Governor Walker had announced an opioid epidemic and a response plan to it. We've lost some of that focus. And we all know that the opioid epidemic has gotten worse under COVID due to the lack of contact and some of the situations that COVID's created. We're trying to get back into that. Domestic violence is up. That is a health department. That's a problem. And the health department is part of that solution. Suicide's up during this. That is a constant situation the health department has a piece in. And then you add all the new created problems, like the fact that screenings are down, just cancers. We're catching late stage cancers because we're not getting the preliminary screenings. People are afraid to go to a doctor's office or a hospital for those basic services, right? So they're not getting their screening colonoscopies. They're not even going in and getting screening blood work or lab work. So we really need to be echoing that. We can't lose the focus of the health department. TB's up. We're in a syphilis epidemic right now. We need to be working those programs. So I need to refocus some of the public health nurses on their core duties. And we can't just ignore the day-to-day business of the health department to be the COVID-19 department. So
Joe, thanks for let me jump in real quick. I do have a question from a member for you, Mr. Dunbar.
Thank you, Mr. Chair, and thank you for presenting today, Joe. And I appreciate what you said about the health department not being the COVID-19 department. At the same time, we are still in the middle of the pandemic, and so I have a COVID-19 related question. I saw a report this morning that the municipality is revisiting and potentially reducing our testing contract, and that the guidance from the health department has changed. And again, this is misreported, to ask that only people that are symptomatic get tested. And I'm wondering if that's true, and if it is, we've heard during this pandemic that if you have a test positivity rate above 5%, that means you're not testing enough, that there's a lot of potentially asymptomatic or otherwise not caught COVID circulating in your community. And I was trying to look it up right now. The last time I saw the test positivity rate in Anchorage, right, so on Tuesday, here it is, 9.86%. So what about that number indicates that we should stop testing asymptomatic people, or is that was that misreported?
Well, that is misreported. So I haven't read the report, so I don't know the one you're referring to. So the answer is,
I'm sorry, it was in Alaska Public. It was in Alaska Public Media, just so you could.
Okay, I was there this morning. I didn't see that, but I will take a look at it. But to answer the question, CDC guidance on who should be tested is very clear, and we like to use them as a national standard. And so the CDC guidance has talked about vaccinated people that are asymptomatic, that haven't had a significant exposure being defined, shouldn't get tested. And the reason for that is that you haven't had a significant exposure. So you were in a room casually for 3 minutes with someone who may have had a positive test too. So that isn't a significant exposure. The piece that I think that people are referring to is who should get tested. And we're trying to message that better. As you know, wait times are pretty significant in some of the spots. Tested 1,475 people on 5 October. So yesterday we tested just short of 1,500 people. I don't envision changing that. The question is that we need to go out to bid for a provider. That could be a question that we put before you, or we put before the mayor to put before you as a group for funding. So I don't think anyone at the health department is not saying we don't test. We want to be tactical in those tests. So the question is, at $98 a test to the MOA, do we want to test everybody? We need to present some options to the assembly and say, we could test people that are symptomatic. We can do testing of people that are vaccinated and are symptomatic. We can test all, or we can include surveillance testing for businesses as we currently do. We have no choice. We can also talk to the assembly about, would you like us to have a cost recovery model, which means we try to bill their insurance. We have the vendor try to bill their insurance. And then if not, we foot the bill. But I think, as we all know, there's a lot of opportunity to refine the program because it's been ongoing. This is essentially an extension of a June 2020 test award. And prices have dramatically dropped because when we set this contract up, there was very little operating labs that had the ability to run the COVID test. Now, over the last year and a half, everybody's got into that game, which has dropped the per test price way down. And so that is just something we're looking at, is finding the most cost effective choice. Sorry, sir.
Thank you.
Mr. Dunbar, do you have a follow-up, or are you good?
Yes, I do. Can you hear me? You're frozen on my screen, Cameron.
I can hear you.
Okay. Well, thank you, Joe. I appreciate that. That all makes a lot of sense. And certainly if we can find a contract that works better for the municipality, that's worthwhile. I'll say, so I just looked up on the website again. It's a story by Nat Hers, and at the bottom it says that there's been a change to AnchorageCovid.test.org, which I believe is a website that we run. And at the very top of that website, it says, visit healthcare testing sites should only be used by people with COVID-19 symptoms or who are a close contact of a positive COVID-19 case, period. And then it says, use this CDC tool to find out if you should get tested. And I assume that CDC tool says, if you makes that distinction, you do it between vaccinated and unvaccinated, but our website doesn't. And so I don't know if that's always been that way or if there's a change there. But I guess what you said seems reasonable to me, but just like a person just reading this, I think, I think might be a little bit confused, and that might be what caused the confusion in that report. But anyway, thank you. I appreciate it.
Thanks.
Yes, sir. And we'll look at that. We are daily doing analysis of the website, making sure nothing's broke. As everyone's been touching it, things do go a little awry. We could clean up any messaging. The message is not to get tested. We're just trying to avoid those people. We have people that come in 2-3 times in a week hoping to get that negative test to get back to work. So this is a classic. They have COVID symptoms. They stay home their 10 or 12 days till they recover. And then their boss says to them, well, you can't come back to work till you have a negative COVID test. Well, I mean, the guidance, that's an example of a person that we are trying to address, because the guidance from the CDC is you shouldn't get tested at least for 90 days, because you're going to continue to test positive as you have the triggers in your blood that are going to, depending on the test, what that trigger is. But sure, we want to make sure that we're being tactical to give the people that are truly sick and not increase the lead time. We were up to 48 to 72 hours. We're down to 22 hours now. I want to be clear, though, what they were referring there, though, in those testing, we actually increased hours at 2 of the clinics. We went from 8 to 12 hours of testing. So the change was actually a positive. We actually, due to a slight downturn from 2,000 tests a day to the 1,500 range, we increased the testing time, because in testing, we pay per test. Vaccination, we pay by the hour. So that's something else we're looking at. But we did increase test times in the last 2 weeks. Last Monday, we upped our amount of testing time, not decreased, just to be clear, sir.
Great, thank you.
And just, I have another question, but before that, just a clarification that Ms. LaFrance and Quinn Davidson are both excused for this meeting, and Mr. Weddleton is joined the meeting at 10:14. I do have another question for you from Ms. Zolotel, but I do want to just make sure we know that we do have 2 other agenda items we need to get to in this hour. So, Ms. Zolotel.
Thank you, Mr. Chair. And this is a question that can be taken offline, but I wanted to raise it while we're having this conversation. I'm interested to know, we originally received a substantial amount of pass-through money from the state for testing. If there were any testing parameters on those funds, and how those parameters may or may not be consistent with kind of what we're doing now. And again, take that offline. So if we go back and look at any requirements under those funds about when testing should be available to what we're doing now.
Excellent. I'll be glad to wrap around. There was very little, I can just say in general, I'll get into specifics offline, but in general, very little guidance provided with that money on what they expected. They do have expectations of equity and fairness and some of those kind of general overarching guidance, but there was no, you must operate a clinic for 8 hours a day or anything. So, but I can give you the specifics of the grant funds and their parameters.
Thank you.
Thank you, ma'am.
Okay, great. And so I want to give you just a little bit of time here to do an update for us, you or Dr. Savitt, and we probably have about 8 to 10 minutes for you here. So if you could try to fit it in with that time frame, that would be great.
Great. I'll take like 2 minutes of it, and I'd like the doc to get to speak, as he's good leaders have good people, and that's what I have. So let me say, though, if you got the Health Policy Committee report that comes through the doc through me to you folks, you'll note that there was some changes in the format. One of the reasons for that, and it's footnoted at the bottom of page 1, with the data breach that the states had and the finding of 44 deaths that were previously unclassified running from April through September, we wanted to make your report more Anchorage centric. The state's responsible for the data, but in Anchorage, we have that unique position of having the one and only, borough level health department. And we really wanted to focus on making the report useful for the MOA. And so that has been some guidance for me to be, there's plenty of data available from the state, but we obviously track that data and are very dialed in on it here at the health department. But I wanted to issue a more Anchorage-centric kind of report. So if you notice a format change, that's what's driving that. It wasn't that we are trying to ignore data, but I get much better data related to us than just kind of some of the reporting from the state due to delays from outlying areas causes not the most accurate, where we're a little more rapid reporting here in the MOA. So thank you. Dr. Savitt.
Sorry, I had to unmute. Okay, so hopefully everyone has received the weekly report that we send out. I'm going to summarize it. I'm going to go off script a little bit. See, somebody is waiting in the lobby. Okay. So when I look at this, I am seeing an opening up of the hospitals to some degree. They are still at near capacity, but I don't see the utilization quite as high as it was before. That's a moving target, though. That can change day to day, hour to hour. What I do see is a trend, what I believe is a trend. I've seen that across the lower 48. Alaska lags behind that. Traditionally, I think we all know that. The lower 48 is coming out of peak numbers. Their numbers are diminishing, which is good. We're starting to see that in terms of our 14-day average, which is down to 130.1 per 100,000. Still a lot to be sure, but it's not at the 140 mark per 100,000 where it had been previously. Our 7-day positivity still remains between 9 and 10. Depends on what week you look at it. It had been around 9 for a few weeks, back to 10, now dipping below the 10%, which is a good thing. Our daily case positivities are still fluctuating all over the place. I think our reproductive number is around 1.17, if I'm remembering that correctly. Now, here's the problem with all the numbers that we're reporting. Remember, we're getting this off of state data, and those numbers are not up to date. What we see day to day probably represents days to weeks beforehand. So the most important thing I can tell you is look at totals with a grain of salt, because they're not as accurate as we would hope they would be. Our vaccination rate is at 65%. I'm a little puzzled because yesterday it was 68.1%. I don't know that the denominator has increased. I don't know of any other eligible pools that have opened up for vaccination. So I'm a little concerned about that number. Our first dose number is about 70%, which is certainly good. If we go to the report itself, we're looking at confirmed. Let's talk about confirmed cases. 47,929 confirmed cases. What does that actually mean? It means that people have tested positive for a variety of reasons. One, they may actually have COVID. Two, they may have a false positive. We're hearing that the tests are not as reliable as we hoped they would be. So there's a percentage of false positives being reported both in the PCR and the antigen rapid tests. I think more importantly, we need to look at people who have been treated. They've been sick enough to require monoclonal antibody therapy, where they've been admitted to the hospital. The majority of those COVID patients do not end up in the ICU. Thankfully, they do not end up on a vent, but they do end up on med-surg floors, and then they're there for weeks and weeks. That also increases the hospital's total census. So those are not necessarily new numbers, but accumulated numbers, cumulative. So when you look at current hospitalizations, and they talk about the average from week to week, again, all of these things need to be taken with a grain of salt. We know that the total mortality counts have been off. They add 44 individuals at one time, but those are 44 individuals who expired over a period of months, not a day or two. So what I'm trying to say is the totality of this report shows a modest improvement. I don't think it's time to start doing cartwheels and saying we're out of the woods here, because we're not. But I think we may have seen our numbers peak, and I think they may very slowly be on the way down. But remember, when we look at other data from other countries like the UK, there is not a sharp decline like we saw earlier in the year with the advent of vaccinations, where that bell curve just dropped off. It just dropped right down. The UK sees little peaks and troughs. We may end up seeing that because of our vaccination rates. But again, vaccination rates are not the only thing to look at. There's a nice study from blood banks which show 74% of the country represented, and they have had 88% positivity of antibodies for COVID. So there's a big number out there that we don't really know about. Looks like Joe wants to interrupt and say something. Okay, so what I need to tell you is I'm concerned, and I don't want to get into the politics of this, but I'm concerned that we're looking at the wrong numbers. We are looking at positive numbers, which to be sure have some significance, but the numbers that are the most significant that we don't concentrate on enough when it comes to talking about policy are the mortality figures, the hospitalization numbers. When we look at a total mortality figure in the state of Alaska of 274, we are looking at the total number since the beginning of the pandemic, not since the resurgence of Delta. So that number is problematic. I think we're looking at the wrong parameters. We can't ignore the positivity rates and so on, but I think before we start talking about what is best for the community, we need to be looking at the correct numbers. I'm going to stop there because I know that the committee has other business to take care of. If you have questions, I'd be happy to answer those.
Great, and I believe just posted that report into the chat, and we can get it up on the website under the Health Policy Committee today. So if you could make sure that, Joe, if you could, or Dr. Savick, send it to the clerk's office, we can make sure to get it up on our committee site as well. We do need to move on, but I have a question from Ms. Zolotel.
Thank you, Mr. Chair. And this is, again, something that can be addressed offline, but I like to raise it while I'm thinking of it, is if you think there are different parameters, Dr. Savick, we should be concentrating on, I would really appreciate those recommendations. And then whether or not you've consulted as well an epidemiologist. I believe the municipality still is without an epidemiologist. So if you do have someone you're consulting with, to know that information so we can take it in and have a chance to evaluate it. Thank you.
So briefly, we can do a lot of that offline, but Dr. McLaughlin is the state epidemiologist. We meet weekly along with Dr. Zink and others. So we have access to all of those numbers and trends. But if we are looking at what's important is severity of disease and mortality, not people who get the disease and recover, which is by far and away the majority of those people. And those are not the ones that we should be concentrating most on.
Thank you. Thank you, Dr. Savick. And thank you for putting a link into the chat that works, so folks can click on that and review the report. Yeah, and I would just add that if your recommendations, your department's recommendations in terms of the parameters that we should be looking at, if that's something you can develop in writing and get to the assembly, that would be great, because that would be good to have that as a formal recommendation from your department. We're going to move on to the next item under new business, alcohol tax expenditures for prevention, and I'm going to have Ms. Zolotel kick that off. Ms. Zolotel. You might be muted.
Am I back on? Sorry, my computer glitched.
Yep, you're on.
Thank you. So I'd like to invite two individuals to address this with us, actually three. I believe we have Tiffany Hall with the Theory of Change, who can remind us and kind of just put us back into the time and place about why prevention was included in the alcohol tax, since I know she worked on that. And then either someone from the health department, or I believe we may have someone from Agnew Beck who can talk with us about what was funded in prevention dollars and why those programs were selected. The impetus for this item, of course, is we're about to we are in budget season, and we want to make sure we are up to speed and ready to go as we consider these items again. Ms. Hall, are you available?
Hi, thanks very much. I am. Can you hear me?
Yes,
Yeah.
we can hear you. And just to give you some parameters, unfortunately, we have a very short meeting. And so if the next presentation is around 10 minutes, 10 to 12 minutes, that would be great. Thanks.
Absolutely. Thanks very much for the time. Sorry I can't be on camera today. Teams has opted not to recognize my camera. Thanks very much for the invitation. I'm Tiffany Hall. I'm the executive director at Recover Alaska. We are an organization that works to reduce excessive alcohol use and harms. And we were the primary organization leading the campaign around the alcohol tax. And I mention that just to preface that the way the assembly members who sponsored the alcohol tax kind of focused on where the revenue should go was based very largely on both municipal priorities, but also what the community was asking for and what the community wanted in a series of multiple polls that we did. And so just as a reminder to everyone, the ballot measure has three sort of buckets that where the money is designated. So funding for police-related criminal justice personnel, first responders, the public safety bucket. Bucket number 2 is funding to combat and address child abuse, sexual assault, and domestic violence. That's the one we'll be talking about today. And then bucket number 3 is funding for substance misuse treatment, prevention programs, detox, homelessness support, shelter, mental and behavioral health programs, things like that. So just as a reminder, the community was really behind those 3 different focus areas being the recipients of this funding. So last summer, we worked very closely with the Alaska Black Caucus and the Alaska Children's Trust to lead a theory of positive change process. And so part of the other thing that happened when the ballot measure was passed was that there was an ordinance that talked about how it should be decided where the revenue goes. And one of the aspects of that was to try to get as much feedback from the community and subject matter experts as possible. And so we know that the Assembly did as much of that work as they could, and we wanted to try to help with that. And so we just gathered as many folks as we could. We had kind of over 200 people on those calls giving input to where the funding should go. And we decided to create a theory of change with a vision for improved safety and well-being for everyone in Anchorage, and really trying to think about what everyone meant. And so we wanted to make sure to include folks with lived experience, folks who were experts in all of the different subject matter areas, and folks who are experts at reminding us to bring in an equity lens and to make sure that all of the work that we're doing is done through a lens of equity. So both in terms of how the money's given out as well as directly funding some equity. And one of the primary things that came out of that process was the desire to really utilize this money to focus on upstream prevention, as well as address some downstream sort of crisis funding for the day-to-day. So we wanted to help people today who are in emergency need of services, as well as really focus on reducing that need in the future. So looking upstream and trying to fund early education, prevention, just to create a shorter line, as Trevor from the Children's Trust likes to say, not only feed the line, but shorten the line. And so how that ended up looking for the second bucket of prevention is it was essentially split in two. So the overall revenue we were looking at was 11.5 million across all three buckets, which had about almost 2.5 million in bucket one for public safety, a little over 4.6 million in homelessness services and substance use disorder treatment. And then that meant bucket two had just over $4 million. And the way that was split out was around half of it was dedicated to early education, which looked like pre-K classes at the Anchorage School District, Countdown to Kindergarten, Child in Transition. Some was also given to a STEM program at Shiloh Community Development, and then also Alaska Writing Project that worked on youth literacy, teacher leadership. And then the other 2 million was given out as prevention grants, and those were given out through the Anchorage Health Department. And those just actually got out the door in September, I believe. And so a number of grantees have this money that they're working with right now through the end of the year. These will do things like expand services at Cook Inlet Tribal Council, South Central Foundation, VOA Alaska, Denali Family Services, Star, Awake, court-appointed special services. I can read the full list if you'd like, or just to kind of give you a feel. There are a number of providers in domestic violence prevention, sexual assault prevention, child abuse prevention, and also looking at kind of the recovery side of those things. And as well as, an early literacy project at the Muni, and then funding for the Alaska Domestic Violence and Sexual Assault Intervention Program. So 2 Muni programs as well. So I think what I kind of just want to really highlight is that, again, we focused on trying to keep the ratio about 1-to-1 in terms of upstream funding, as well as more day-to-day addressing trauma. This is the only time that prevention has had dedicated sustainable funding. And the thing about prevention funding is that we were not going to see, we'll see some outcomes today and next year and the year after that. But where we will really see these changes take hold is in the next decade, in the future generations of Anchorage. And the more that we continue to prioritize prevention now, this long-term upstream prevention, the less need we will have for these emergency services that we're seeing today. Prevention works. It is proven again and again to work. It saves on average 7-to-1 the cost of downstream resources, sometimes as much as 21-to-1. So hospital stays, fire, police emergency response, all of those things will decrease the more we focus on prevention. I also want to just talk quickly about equity and needing to focus the funds where they are most needed and to close the gaps and inequities in our outcomes. There are health disparities, which is sort of just like code for systemic racism, right? There are health disparities that need to be addressed, and by focusing on populations that currently suffer the most harms and see the worst outcomes, we will raise up their health and thereby raising up the health of our entire community. So I just want to thank you again. I'm going to stop there, and I know that we are limited on time. Happy to talk about questions. I also wanted to just mention that Celeste Hodge Groudon, I believe, is also on the phone with the Alaska Black Caucus, and I just wanted to also see if I missed anything or she had anything to add.
Thank you, and thank you for this opportunity. I heard that we are pressed for time, but I do want to just add again the importance of inviting communities that have not traditionally been invited to participate in this process. And so, as Tiffany shared, over 200 individuals actually had a seat at this table. And I just wanted to mention that again. Thank you so much. Cameron, you're on mute.
Thank you so much, Celeste. I was just saying thank you, Celeste, and thank you to Tiffany for being here, and thank you for all of your work. It's been really, really amazing and helpful for all of us, not only on the Assembly, but for our entire community, to ensure that we're being very thoughtful about how this funding is distributed and used. I don't see any questions at this point in the queue, so we are going to move on to the last item in our new business section, and that is classification of AWUU employees. And I believe that Brandon is here and going to present. Brandon, do you want to begin? We have about 10 minutes, if you could, 10 to 15 minutes, if you could keep your presentation within that time frame. That way we'll have a few minutes at the end for public comment. So.
Thank you, Assemblyman. Yes, by all means. Let me get my camera turned on, and just so everybody's clear, I've got a few of our members here in the office with us. I will make sure to keep it well under 10 minutes, specifically so if you guys have any questions, you can ask specific questions as far as utilities and the parameters for which they work under. Hopefully you guys will have time to answer or to ask those questions so our members can answer them. But while we're here, while we're asking for this, while we sought this out at the Assembly level, and for anybody who isn't aware, there are 3 different classifications of the bargaining units that work under the municipality's purview. A1, 2, and 3. The A2 and A3 status groups do have the ability to strike. The difference being the A3 can strike essentially indefinitely. The A2 status group has a limited striking ability, meaning they can only strike for a limited period of time. And then the A1 status groups do not actually have the ability to go on strike. In lieu of the ability to withhold, the only actual bargaining chip that they have, which is their work, which is their labor, they instead are given binding arbitration. So if they do end up reaching impasse at the negotiation table with the MOA, and they do end up going through mediation arbitration, they will in turn be forced to accept the arbitrator's decision, whether it's in their favor or the municipality's favor. The arbitration is binding, and it's a sword that cuts both ways. We experienced in 2011 a negotiation where we met, we came to an impasse with the municipality. We went through mediation arbitration. We did receive an arbitrator's decision. It was actually 3 different decisions. And the one that we had won on was based on the wages that went in front of the Assembly for the required supermajority vote of 8-3. It did not garner those votes, at which time we, as a membership, voted to go on strike. That vote passed by, I believe the vote was 113-2 that our members had voted to go on strike. We then notified the municipality that we were potentially going to go on strike, and at that point an injunction was filed, preliminary injunction, for which the municipality of Anchorage said that we can't go on strike because we are simply too critical, that if we are gone for even a moment, the risk of potential serious harm to the public would be imminent if something failed. So we actually took that up through the court systems when that injunction was filed and upheld in the courts. We appealed that all the way up to the Supreme Court. The Supreme Court basically weighed in and said that we are the judicial system of the government. Your situation is a situation that is legislative, and so they essentially did not weigh in, and effectively they ruled against the union, saying that this is legislative. That's the way that you've got to change this. Essentially, at that point, we were forced to work under the last best offer. We weren't allowed to go on strike, and the tenets of that A2 bargaining group that I spoke to at the beginning was that we should be allowed to strike. Regardless of whether or not in the language right now it says that we can, we know, based on history, factual history, that the municipality has argued that we are essential and that we cannot go on strike for even a moment. And that was the municipality's own argument in their injunction. There's no reason to believe that they wouldn't bring forward the same argument if that situation were to present itself again. I will say that when that happened in 2011, We took our licks, and our members stayed at work, and they didn't stop. The following negotiation, we again reached impasse, to which we went through mediation, arbitration. We again received the arbitrator's decision. It again fell to garner the required supermajority ratification vote. At that point, our membership had a decision to make, and that was whether or not we would or wouldn't file to go on strike. We knew that it was futile. We did not file to go on strike. We simply worked under the last best offer. At this point, we have a membership that is working on a decade of knowing that they don't have fairness at the bargaining table. And that really is what this is about. It's not just that we are health and safety essential, because we are. And we oftentimes don't forget about this. And I don't mean to sound like a broken record, because I know some of the assembly members on here have already heard this. We are health and safety essential. But this is also a fairness issue, because we know that our members aren't allowed to strike. Regardless of what the language says, regardless of what the municipality will claim, we have proof that we aren't allowed to strike. We know that an injunction will be filed, and they will prevent us from actually withholding our labor, which means we don't have the ability to strike, and we don't have binding arbitration. So we honestly can't negotiate in good faith. And that's the whole point of being able to sit down and negotiate with the employer, is so that both parties can walk away not feeling like they got the sun and the moon, but also knowing that they're valued and they're able to show their value. So to that, that's the extent of that's the meat and potatoes of this. I can go into the intricacies, but I would actually rather open this up so that if anybody has questions that these members can answer specifically, it's all yours, Assemblyman. You're muted.
There we go. Thank you. And thank you, Brandon. And I want to hand it over to Mr. Dunbar. He would like to add a few things to this, and then I have a question in the queue from Ms. Zalatel. So, Mr. Dunbar, do you want to add anything to the presentation at this point?
Yes, thank you, Mr. Chair. And you were a little bit choppy there. I'm not sure if it's on your end or mine. I want to thank Brandon and Heidi for emailing us some documents earlier in the week that related to the injunction that he references. And if people have that before them, I also sent it to Carissa. I don't know if Carissa can put it up on the screen for people, and also have it posted to the website for people to see. Okay, here we go. So if you go to page 4, or I guess it's page 5 actually, page 4 labeled in the document, page 5 of that motion for injunction. Let's see here. There it is, right here. So this is why it relates to the Health Policy Committee. So I don't want to read the whole thing, but basically it says the strike poses a direct and imminent threat to the health, safety, and welfare of the public. The public health is directly impacted by the quality of water it drinks and the proper treatment and disposal of its wastewater. And there's a lot in there about even this whole document is hundreds of pages, but that kind of gets to the crux of it. Carissa, could you go to the next page? Here we go. Again, improperly treated or untreated water and wastewater poses both immediate and long-term dangers to public health. And then there is a, let's see, where's the statement? Keeping the water and wastewater systems properly staffed, monitored, and repaired as necessary requires enjoining the strike and keeping the union members at work or returning the union members to work immediately. And there's some more language in here about that immediacy, because again, this is a motion for preliminary injunction. This is the court, this is the municipality, us, asking the court to step in and prevent this strike from ever occurring. And there is some discussion in this document about what the municipality had stated about, or the municipal attorney had stated about, if the union were to go on strike, then the managers are supposed to step in and run the facilities. But even in our own legal documents, it makes it seem like it's very unlikely that would work, or that would work for anything but a very, very short period of time. And thus we are asking for a preliminary injunction. So I guess my question for the folks that are here, the union members that are here who have that technical expertise, if they could provide a little bit of insight into, what does that look like if the union members go on strike? What does the staffing look like at those different Awuu facilities? And how long in your estimation, could Awuu continue functioning before it impacted the health and welfare of the community? And then I guess if you have any insight into how, the health and wealth, what kind of health impacts would result from that strike?
So thank you, Assemblyman. And I'll start real quick, and then I'm gonna hand it off to my guys here. To be very clear, when we're talking about emergency situations and things that come up, because we all know things that come up and they come up on short notice. Even right now, we have some of the supervisory people that may or may not be able to fill the role that you were just alluding to, Assemblyman Dunbar, as to whether or not we have supervisors who can fill those roles. We have a couple supervisors right now who are out because of COVID. And if our utilities were to go on strike today, and that's how I'm going to pose it, and I'm going to let my members kind of answer that for you. And I'll make sure to introduce yourself and kind of explain from your point, if that's okay. Go ahead, James.
Okay. James Christenberry. I've worked with the utility for over 20 years now. I work out at the Clutna Water Treatment Facility. Honestly, when it comes to the safety, public safety, you've got your water issues, lack of water. You've got your wastewater issues where it backs up, and you've also got fire protection that people forget about. All of those would be very important, very crucial. As far as who would fill in, we have 5 different plants, and then all of the piping. The 5 different plants, you have a superintendent at each plant. So you'd have one person at each plant that could run that plant 24/7. Our plants run, 3 of the 5 run 24/7, and the other 2 run 40 hours a week. So it'd be very crucial. I don't think you could man it with one person. You would have to bring other people in at a greater cost, I'm sure, and at limited abilities.
Hi guys. Hey, I'm Danny Srico. I've been with AWW since 2007. I am one of the operation and maintenance system maintenance foremen. I'm in charge of the collection system, basically all the pipe that's underground. There's approximately about 800 miles of pipe. I think a lot of people don't realize what's underneath your feet. So there's about 800 miles of just sewer mains. There's probably about the same amount on the distribution side. We take care of 43 lift stations, and what that is, just to give you a simple education real quick, sewer mains fall by gravity. So when you get down to a low point, because of the geographic of Anchorage, we have 43 lift stations, 28 in Anchorage, 11 in Eagle River, 2 in Girdwood. So sewer runs down to a certain point, we got to have a station there with pumps inside that takes that sewage, puts it up a force main, gets it back up to gravity, and gets it all the way to Aspen. I can tell you I have 13 lift stations that have a 2-hour retention time or less. And what that means is once you hit the high water level, you have 2 hours till you have an SSO. Pump Station 2, which is down in Westchester Lagoon, has a half-an-hour retention time, and that averages about 11 million gallons of sewage a day. It's half of what's going into Aspen. So I would say we are very critical to have the knowledge of the system to respond that would prevent a sanitary sewer overflow and have an environmental nightmare that would also impact our 301H waiver for Aspen. And if we lose that, it's millions of dollars to the ratepayers of the municipality. If you guys have any other questions, let me know. But hi, I'm Danny.
Thank you so much. And I do have one comment from Mr. Dunbar. I just want to give a heads up. We just have a few minutes left in the meeting. So I want to first thank you all for your presentation and for being here. This has been really helpful. Mr. Dunbar, do you want to have a closing thought?
Yes, thank you, Mr. Chair. And I'll first say that I apologize that our assembly memorandum isn't completed yet. I hope to have that on the addendum, at the very least, laid on the table and attached to the Assembly ordinance that will summarize some of this information and some of the stuff that's in this injunction. Our legal department has just been stressed by the last couple of weeks of activity on other topics, and so that has delayed the Assembly memorandum. Carissa apparently read my mind because she already scrolled down to the page I wanted to close with. And I probably should have opened with this, but I think it's worth reading here. And I'll just read it for those who maybe are on the phone. Again, this is the municipality's memo in support of a preliminary injunction. This is our own legal argument. This is what we said when we tried to prevent the strike from occurring. Improperly treated or untreated water and wastewater pose both immediate and long-term dangers to public health. Awuu depends on its skilled employees to fulfill its health and safety obligations to the public. According to senior management at Awuu, if the union employees were to strike, non-represented and executive employees would have to maintain the system for as long as they were able. That time period is extremely short, so much so as to be non-existent, a maximum of 48 hours. Given the start date of the strike tomorrow, the municipality's ability to ensure safe, reliable water and wastewater treatment potentially ends as early as Sunday morning. Keeping the water and wastewater systems properly staffed, monitored, and repaired as necessary requires enjoining the strike and keeping the union members at work or returning union members to work immediately. So that's all. Thank you, Mr. Chair.
Thank you very much. And again, thank you to the folks that came to present. Really appreciate it. We do have time for potentially one member of the public to speak. Hello. Is there anyone in the public? It sounds like Mr. Haberman, you're there. If you could please state your name for the record, and you'll have 3 minutes.
My name is Paul Haberman. We follow the public process. When the public process is done appropriately, decision made by the governing body, more likely in the public interest. First note, the only item that was on the website for the public to follow this meeting was the agenda. There were critical documents that were discussed, including the health reports that were presented earlier in this meeting, and they're not there, and it's difficult to follow. And note that you assembly members have a way to link in and visually see stuff, but the public does not. This has got to end. The public and yourselves need to visually see the meetings, not just audio. The Ports Commission is happening today, does both, and they have a better handle on the situation to be able to connect and for the public to be involved. And then the last thing to say is this, I'm going to be brief today. My continuing alarm, the way the chaotic situation at the assembly meetings, I'd like to whoever's listening, including press. Assembly, these are public meetings. It's a time for people to respect, listen, and not be disruptive in any way. And disruptive also includes waving hands in a room, and that's disruptive. The attention should be on the person who's speaking at the microphone, whether it's the member of the administration, the assembly, or a member of the public. It's not to be creating a situation. The end result is whatever decision by the governing body is going to be less likely in the public interest if these situations do not end. And I just say this last thing is that I see no hope, and I also see the end result of this is particularly what's gone on in the last several meetings in Lusek Library is many people will refrain from even being involved at these assembly meetings from the public. They will permanently end being at those assembly meetings, and they'll be ending their remoteness because what they're seeing is an alarming situation that they just basically fear and of any of their involvement in the future with what's gone on for the last several nights over the since last Tuesday. And thank you, and I wish you all the best. And last thing is, you've got a Point Commission meeting scheduled at 12. You've got a Public Safety Committee starting at 11:10. It's critical that you do not have these kind of conflicts, so the public doesn't have to choose to go between one or the other. And also, like last night, the school board meeting was holding a meeting at the same time as you did, and issues that were addressed that you were having last night were also issues that were addressed at the school board meeting for action items, and this is wrong. And thank you very much with approximately 11 seconds to spare.
Thank you, Mr. Haberman, and thank you everyone for attending the meeting today. This meeting is now adjourned. Have a great day.